the IABDM COVID-19 Sanity Series for us to, be happy, because Tony Robbins always says the only time you're happy is when you're making progress. And so by taking this course, you're all making progress tonight, and that's a wonderful thing. So tonight we're going to talk about compatibility. What's the definition? The definition of compatibility, oh, by the way, most of these slides were taken from what we call the training. When I give the training and teach people how to be a biological dentist, most of the slides came from that part of the course. So you're really all quite fortunate, because you're not paying money for this. Usually people would pay for the first full 3 days, and so you're getting this for free. It's great. Biocompatibility, the condition of materials not harmful to living tissue or a living system by not being toxic or injurious and not causing an immunological reaction. Those are very important qualities. This is part of the Huggins-Grube protocol. And Huggins always said, the most important thing was to remember the oath that you took on graduation day that said, first, do no harm. The immune system. Primary function of the immune system is to recognize self from non-self. That's basically what white blood cells do all day long. They swim around, they look for your initials, or as Hal used to say, your license plate on every single cell. The moment they see that there is no license plate or somebody else's license plate, the immune system is required to figure it out and decide how hard is it going to work to get rid of non-self. And this is all accomplished via the histocompatibility complex. That's the fancy word we use instead of saying license plate, found on the surface of the cell membranes. There are different degrees of reaction to something that is identified as non-self. Now, some people think that it's okay to say that a material is suitable or not suitable. Well, we don't think so, because there are different degrees of reaction. There's a big difference between somebody who eats a food that they're slightly allergic to, and they might not feel so great and maybe come out with a little bit of a rash. There's a big difference between that and somebody who eats a peanut and they're allergic to peanuts and they go into anaphylaxis. So there are different degrees of reaction to something that is identified as non-self. National Academy of Science, this is an old slide, I think this was 2015. It says 15% of the US population are chemically sensitive. So there's an old slide, so you gotta know that all these numbers are much higher. 55,000 chemical compounds are produced annually. 3,000 chemicals are added to our food supply. 700 chemicals to our drinking water. And that's not necessarily intentionally added to the drinking water. It's just that when we have our water filtration systems, they don't have the capability of filtering out Viagra, filtering out antidepressants, filtering out a lot of the drugs that people are taking. So those drugs and those chemicals just get in our water because they were not filtered out. And then we've got another 10,000 chemicals used in the processing and storage of food. We cannot control it all. As a matter of fact, I can't even pronounce the names of those chemicals that are in some of our foods. What we can control, though, to a certain extent, are the dental materials that we place in our mouth. And of course, we can control the food that we eat too. So, biocompatibility testing. This is what you have to do first before you restore anybody's mouth. And there are a lot of different ways to do biocompatibility testing. The first, of course, would be blood tests, which is what we do at Biocomp laboratories, and that's an immunological test. In other words, we're going to mix the blood with a dental component and sit back and kind of watch to see what the white blood cells do. There's a lot of talk now with the COVID-19 that they're talking about looking at antibody testing. Well, they're not testing for the COVID vaccine, the COVID virus directly, not at all. What they're looking for is to see if your bodies had formed antibodies against it. And so with biocompatibility testing, we look to see, what are the white blood cells doing? Are they freaking out, or are they okay with it? There's also muscle testing. For a lot of people who are really astute at muscle testing, this really is the way to go. Unfortunately, muscle testing has been deemed by the powers that be to be only 70 to 80% accurate. I've always found that to be a kind of humorous comment, because the Mayo Clinic has already said that they are only 35% accurate on their diagnostic tests. So for somebody to do muscle testing and be 70 to 80% accurate is actually quite good. There's EAV testing, electroacupuncture by Vol. And this is something that Dawn is a master of, and she teaches a whole separate course on how to learn how to do EAV testing. In EAV testing, what we're looking at is the meridians. We're testing the meridians, we're testing the amount of energy passing through the meridians. When you mix that with the dental material, if the body reacts to the dental material, your EAV testing is going to react also. So that's another way of testing for dental materials. There are various different kinds of EAV systems out there. One is called Dental 2000. Little bit of a learning curve on this one. There's also the SCASIS, which was an old system. Again, learning curve is pretty steep. Then came the QXCI, which was a souped-up version of the SCASIS. And then my favorite, which has an unbelievably steep learning curve, is the CyberScan. I love the CyberScan because it not only tests for dental materials, but it also tests for personality disturbances, and it tests for your mood, and it tests for all kinds of things. But like I said, if you get into CyberScan, you get ready for a steep learning curve. In vitro testing. This is what we do in biocomp laboratories. There are presently 2 labs in the country, in the United States, that do testing for dental materials. My company is called Biocomp Lab, and the other company is called Clifford Testing. So a lot of people ask the question, what's the difference? What are you looking at? Well, Biocomp Laboratories, we are testing the immune response of serum in direct contact with the dental component. You should only use Biocomp Laboratories for compatibility testing if you really care about the health of your patient and what you are exposing yourself to every day. So not only are we concerned with what we put in somebody's mouth and how it's going to affect their body, because they're going to be sucking on it 24 hours a day, 7 days a week, but when you put it in the patient's mouth and you have to adjust the bite, and you're touching it with a high-speed drill at 80,000 RPMs, you are breathing that material into your lungs. And if you're not wearing a long sleeve jacket, you're getting some of those particles on your skin, on your neck, on your forehead, everywhere. So it's something that you need to be concerned about also as a dentist. So why do I say that so boldly? That you should only use Biocomp if you're interested in the patient's health. Here it comes. What's the big difference between our test and the Clifford test? Newsflash. Aluminum comes off ceramic crowns and fillings. Now I know that there are a lot of dentists out there that really don't want to hear that from me. Why? Because they like aluminum crowns. They like ceramic crowns that are 10, 20, 50% aluminum. Why? Because they're really pretty. The patients love you. They think they're gorgeous. And everybody is happy, except they're happy fools because they don't understand that the crown that you just put in their mouth is 50% aluminum. Well, there are people out there who say, excuse me, people out there who say aluminum, once it's mixed, becomes aluminum oxide. It becomes like table salt, like sodium chloride, never to be separated again. Sodium is toxic. Everybody knows that. Chlorine is certainly toxic, but when you put the two of them together, you have sodium chloride, and it's perfectly safe. There are a lot of people who believe aluminum oxide never separates, and it's also very safe. Well, we have something called nanoparticles, the new science. A nanomaterial is something that is 1 nanometer to 100 nanometers. It has to be under 100 to qualify as a nanoparticle. The very small size that they are gives them greater surface area and greater volume to mass ratio. These nanoparticles have very unique mechanical, chemical, electrical, and magnetic properties. These properties make them actually more reactive compared to their bulk counterparts. Now, I've had people say to me, do you know, Dr. Grube, that you get aluminum from broccoli? Yes, I do know that you get aluminum from broccoli. But number one, it's only 5% aluminum. And number two, those aluminum particles are so large that they pass out to the other end. It's the smaller particles that we're worried about. When Dr. David Warwick gave his lecture in Brazil, he literally blew us away because that it's not just the mercury vapor that we're worried about. Mercury that go flying in every direction, land on your shirt, land on your neck, land on the patient's gown, and then when we're finished taking out the mercury fillings, we proceed to put a composite filling. We've already taken off our face mask. We've already changed our gloves and hopefully have put on a new pair of gloves. But we're sitting in that room where those little teeny nanoparticles, billions of them, are outgassing mercury vapors. So it's the opposite of what you would instinctively think. It's the smaller the particles that makes them more dangerous. So again, these properties make them more reactive compared to their bulk counterparts. They interfere with normal physiology. They penetrate cell membranes very easily, including the organelles. They go right into the mitochondria. And they can penetrate the blood-brain barrier. And this all came, if any of you want, to know where my science comes from, I'd be very happy to give it to you. This is Nanotechnology Reviews. This is pretty recent, November 2019. In the Journal of Nanomedicine, there was an article called Application of Dental Nanometers and Potential Toxicity to the Central Nervous System. Well, we found that you have nanoparticles from dentistry found in light polymerized composite resin and bonding agents. And isn't that what we tell all our patients is perfectly safe? Oh, so long as you have a composite filling in your mouth, you're okay. So you don't have one of those ugly black mercury fillings in your mouth, do you? And the patient invariably says, oh, no, I don't. I had all of mine removed. And look, they open their mouth, they say, look, see, I've got all composites now. Well, yes, more than half of the composites on the market today are loaded with aluminum. Okay, they're found in the coated materials for implants. I'm old enough to know that when they first started doing implants, we actually told the patients they had a 5 to 10 year survival rate. Why was that? Because the body recognized that titanium implant as non-self, and when it knew and realized that it could not push it out, it would create an abscess or a pocket of fluid around the implant. And so in 5 to 10 years, the implant would become loose and it would fall out. Well, then scientists discovered that if they put aluminum oxide on the outside of the titanium implant, the bone would adhere to it a lot better and give the implant a longer shelf life in the mouth. Well, that's fine and good, except for the nanoparticles and the oxidation particles that come off the titanium implants. For instance, titanium dioxide and titanium trioxides. These are very, very small, teeny little molecules that can cause havoc in the brain and in the rest of the central nervous system. We've got in dentistry bioceramics. We've got crowns. Everybody's always asking me, well, gee, how's my CEREC crowns and my, what's the other one that's become very popular now? I just had a blank senior moment. There's another one that's very popular that everybody likes. It has the number 10 in it. Does anybody know what it is? Anyway, endodontic sealers, the cements that are mixed with gutta-percha.
Emax.
Emax, right, that's it, Emax crown, very high in aluminum. And we even have aluminum nanoparticles in mouthwash. So that's a problem. Journal of Nanomedicine says they're similar in size. That's how small these nanoparticles are. They're actually similar in size to DNA, to the proteins in our body, viruses, and the biological molecules like enzymes. As everybody knows, every function in the body requires an enzyme. You do not go from A plus B goes to C without having an enzyme there. Well, these nanomicron particles botch up the enzymes and keep your body from being able to function. Nanoparticles are a type of mesoscopic system that possess a special surface effect that once created, make once benign materials totally exhibit cellular toxicity. For example, titanium dioxide. Zinc oxide as a nanoparticle is toxic to cells. And I bet you today there's still many dentists who are putting zinc oxide inside teeth that they're trying to save from needing a root canal. If the cavity is really deep, this is what we did in the old days. We put zinc oxide inside the cell. These nanoparticles may even be inducers of oxidative stress and inflammation. So this is where it all begins. Journal of Nanomedicine again. So we have other nanoparticles besides aluminum. We have zinc oxide nanoparticles. We have silica nanoparticles. Calcium phosphate from zirconia implants. That's what they're putting on the outside of zirconia implants, calcium phosphate. We've got calcium fluoride, titanium dioxide, which increases oxidative stress in the brain. And then we've got nanohydroxyapatite crystals, which are being used for bone grafts. Okay, the Journal of Nanobiology and Genetics. This is recent, December 20th, 2019. The inhalation of nanodispersed aluminum oxide into the lungs of mice. This was just one quick little burst they gave these poor little mice. And these mice suffered from hemorrhagic infarctions, hyperplasia of the lymphoid tissue, acute hyperemia, and aluminum nanoparticles they decided was more toxic in comparison with their microdispersed analogs. So if you're a dentist and you're drilling on an aluminum, a high content aluminum crown, and you're not wearing your mask, and your mask has to be small enough to stop this, you're going to have these particles in your lungs. And that's not a good thing. Not good at all. This is an older paper. Hayasibara, I think I pronounced that correctly. They studied the effects of fluoride and aluminum ionomeric materials on S. mutans biofilm. So what they looked at was how did the aluminum and fluoride coming off fillings, how did that affect mutans? Well, they couldn't have done this study if it wasn't for the fact that the fluoride and the aluminum did come out of the fillings, right? Interesting. This is another separate study that said synergistic effect on the destruction of bacteria when fluoride and aluminum leached out of Z100. When I first started doing composites, Z100 was the rage. Everybody was doing it. And then now Fuji became very popular, Fuji Ortho. and Keytech fill, and Vitromere. These materials are not only loaded with aluminum, but the aluminum does come out. So if you're going to have a biocompatibility test done for your patient, you got to make sure that you prepare the patient for the test. So how is it done? Well, the patient should be NPO for 12 hours. For those of you who don't know those initials, that means no food, nothing by mouth. So 12 hours later, after, assuming the patient had an early dinner, they haven't eaten after 7 p.m., then they're going to have their blood drawn no sooner than 7 a.m. the next day. 2 vials of blood are drawn from the patient's arm, and these go into a red top test tube. And of course, there's exceptions made for patients with diabetics. If they can't go that long without eating something, you let them have something light. And let me go back to that. So the reason for not allowing the patients to eat for 12 hours is because the patient may have a lot of food allergies. And if they have food allergies, their immune system is already stressed out dealing with the food allergy, and it's difficult for us to get some good numbers. So we like the patient to be NPO for 12 hours. Well, in order to draw the blood, the first thing you must do is assure the patient so that they can be calm during the procedure. Now take a look at this fellow. He's pretty calm, right? I think his eyes are going to fall out of his head. Okay? Compatibility testing and drawing for blood is it's the exact same way that you would draw if you were going to do a CBC. That's a complete blood count for a patient. And the antecubital fossa, which has a very large vein in the middle, is probably one of the easiest veins to go for. It really is. I highly recommend you practice with that one. Once you've drawn 2 vials of blood, then you're going to place the blood inside a centrifuge and spin it for 20 minutes and separate the cellular from the serum portions of the blood. And that's what it looks like. Before centrifuge, the whole tube is filled with dark blood. Then after centrifuge, you see the plasma on top, layer of leukocytes, and then the packed red blood cells at the bottom. The straw-colored plasma on top is what you want. We want to pour that off into the transfer tube, freeze it, and mail it overnight to Colorado Springs. Now, I know a lot of you are already doing this because you're doing PRF and PRP. You're doing facials with PRP. You're using PRF for sockets and cavitations, and so you're already used to doing this. Once the serum comes into the laboratory, it's then separated into 99 test wells, and an antigen from each dental materials are mixed into those test wells and mixed with the serum. And then that little machine does a little bit of shaking for about 20 minutes. It's then passed on to an optical density scanner, which tells us just what kind of a reaction did we get. Now, I know this picture is very, very small for all of you, but you can see some of those little dots are super, super white. That means that when the white blood cells were floating around the test tube and they saw the antigen, they freaked out. They called all their friends. They underwent a procedure called protein precipitation. All their protein came out, the antibodies came out, and the white blood cells clamped around this foreign material because they were sure that it was going to kill the patient. That we call a highly reactive material. If you notice in the middle, there are a couple that are just slightly opaque. We would call that a moderately reactive material. And then there's a whole bunch that have no whiteness at all, so those are all least reactive. But the ones that have absolutely no whiteness are on the lower right, and those are perfectly clear because that's our control. There is always, always, always going to be some kind of reactivity to a dental material that is not you. If it's not self, the body is obligated to react. It's just you want to know how much reaction you're going to get. By the way, the optical density scanner shines a light through each one of these little test tubes and then gives us an exact reading of just how much opacity you have in the test tube. And then we get our results. The results are dependent upon the amount of protein precipitation And again, most reactive are the ones that are white, white, white. Then we've got moderately reactive, they're somewhat opaque, and then least reactive are almost clear. Just because something is the least reactive list does not mean that it is good for them. And I like to give the analogy, if I had a table, and on that table I had a bottle of Coca-Cola, Pepsi, let's say root beer, Sprite. And I asked the question, which of these 4 sodas is going to be the least reactive in the body? And I would think most of you would agree that it would be Sprite, because it doesn't have the caramel coloring in it. It doesn't have any caffeine in it. Still has lots of sugar though. So of those 4 sodas, Sprite is the least reactive. Now, does that mean that Sprite is good for you? Absolutely not. It just means that out of those 4, it was the least reactive. So when you look at our compatibility test, there will be a section with non-precious crowns, non-precious metals. Does that mean that those crowns are good for you if they're in the least reactive list? Absolutely not. It just means that of all the metal, non-precious metals, those were the least reactive. It doesn't mean it's good for you at all. Okay, and that is a picture of what the compatibility test looks like. If we could flip the first page, you would see a list of all of the favorite materials that that particular dentist likes and uses a lot of. So for those of you who don't even want to open the book and look inside, all you have to do is flip to the first page, and we'll have a check mark next to your favorite dental materials if the patient is okay with it. So how do you choose a dental material? You want to pick something that, that's going to last for a reasonable amount of time, but you must remember that we are more concerned with the life of the patient than we are with the life of the restoration. So what if the patient can't afford testing? Well, in this day and age of COVID-19 and everybody's giving out free webinars and free information, for the first time now in history, I'm going to go ahead and tell you which dental materials consistently come out safe for 95% or more of the population. So get your pens and papers out. So when it comes to dentures and temporary crowns, polymethyl methacrylate wins hands down. You've got jet acrylic, you've got Admira, you've got Telio. Telio comes in a cube that can be put into your CEREC machine. It can make up to a 5-unit bridge, and they are drop dead gorgeous. I've been using Telio for about 5 years now. I have yet to come across a patient that's not okay with Telio. I'm going to stop calling them temporary crowns because they actually fit better than the permanent ones. No kidding. Bonding agents, G-bond and SE-bond across the board, very safe. Composites, pretty much all of the Voco products. They're not an open company. I wish they were. I would buy stock in them. And Grandio, not to be confused with Grandiose. Grandio is a fantastic composite, safe for 95% of the population. Grandiose is not. Do not confuse those two. And then for crowns, like I said, I use Telio. I use Diamond Crown for anterior crowns because they just look so much nicer. And they're safe. And of course, there's zirconia. You can get zirconia cubes now. And nylon rib bond. Those are the materials that are safe to put in the patient's mouth, okay? Just know that you are taking a chance when you don't do some sort of testing ahead of time. Remember, your first goal is to do no harm. And that's my presentation. I hope you enjoyed it. Are there any questions?
Yeah, flip it around so we can see you.
Oh,
I have a question.
yes.
For the bonding agents, so it was G bond and SE bond. Now, is SE bond
S as
product?
in Stephen, S as in Stephen, E as in Edward.
So is that under the G bond brand, or is that a different brand?
No. It's a separate brand. I think it's not made by Kerr.
Okay.
I don't swear to it, but I think it's Kerr.
Okay.
The difference between the two, I love G bond because it's a one-stepper.
Yeah.
You paint it
Yeah.
in. You count to 20 seconds painting, 10 seconds drying, and you're done. Whereas SE bond, you got to paint in your primer, and then you got to paint the bonding agent. That's a pain, especially if you're looking and you see red blood cells coming up from the gingival sulcus. You don't want to do 2 steps.
Yeah. Oh, I think it's clear fill. Okay.
Blanche, you have a question on here. Somebody is asking, what's the typical cost?
The typical cost for the biocompatibility test?
Yes.
$400.
I had a question.
Okay.
Sure.
What do you think of, first of all, thank you so much for your wonderful presentation. I really enjoyed it and learned.
Thank you.
What is I had 2 questions. What is your opinion on bond and provider health? That's 1. And 2, I'm a pediatric dentist. So what kind of liner would you recommend under deeper restorations, composite restorations, if not Vitro bond? That's what I currently use, and I recognize what you said.
Yeah, you can't. Yeah, I'm not a lover of liners at all. So I would go right to the. If you ozonate the tooth first before you paint your bonding agent on, you don't need a liner. Because when you ozonate the tooth, you're killing all of the microorganisms that are in those, 2 millimeters of dentin that's left. Sometimes less than 2 millimeters. Sometimes you're really close to the pulp. Then it's even more important to ozonate the tooth. And the closer I am to the pulp, the longer I will ozonate.
Okay. And what about?
Once you do that, once you ozonate the tooth, and if you're a little bit nervous and you ozonate it a little bit too much, and then you look at it and you see it's a little bit dehydrated, well, then you go ahead and wet it again with ozonated water, rehydrate the tooth, blow that out quickly, go right to your bonding agent. That's been proven to be the most effective thing for teeth. The dentin will remineralize a lot better and a lot faster if there is no separation, if there's no liner in between.
Okay. Thank you.
Okay.
And
yeah,
what about?
Get used to ozonating your teeth first before you put any bonding agent or composite in. As a matter of fact, ozonate your teeth also before you cement a crown on.
Okay. Thank you. And what about bonding agent and provider health? Any comments on that, please?
And provider health, I'm not sure what you
as the dentist.
Yes, as the dentist, if it's the inhalation of, I always wonder about bonds and the toxins involved in, because I have always held
my breath the 10 seconds that I'm drying the bonding agent. You bet.
Yeah.
And make sure that your dental assistant has the large suction right next to the tooth. It's funny, we started wearing masks when we were removing mercury fillings. And then I realized, wait a minute, I need to wear a mask when I'm cutting a root canal tooth. Those microorganisms are much worse than mercury. And then I realized, wait a minute, I shouldn't be breathing when I'm blow drying bonding agent. I don't want that in my lungs. So I just got into the habit of holding my breath. I do that also when I'm doing an examination. I don't want to be breathing in somebody else's cooties.
Thank you.
Cooties. Okay, so you either get into the habit of holding your breath or wear your gas mask all the time. The thing is too heavy. It's just too heavy, too hot to wear all the time, right? Okay, any other questions?
Blanche, I have a question. I'm just behind.
Sure.
I'm behind you, so you can't see me, which is fine. What about
fine.
children? What age is too young to do this test?
Oh boy. Well, the problem is you have to draw blood from the child's arm. So I'm not a lover of sticking kids with needles. So I probably would use muscle testing or EAB testing with a child before I did compatibility testing.
Okay.
Really.
And what about any prerequisites?
Dawn.
Yeah.
Wait a minute. You remember I'm the needle phobic.
I
Remember
know.
that?
Oh, I know. There's a picture out there somewhere of me sitting on you.
Yeah.
Okay.
So any age is okay if you can get blood from the child.
The reason
Good luck with them.
the reason that I'm asking is, and most of you know that Jess Clifford just passed away, but Jess had told me at one point in time that they didn't like to do testing on children under the age of 12 because their immune system was all over the place. And they found that they could test them one time and maybe they'd be reactive to one thing, but then they'd do it again and it would be different. So he just didn't like to do children under the age of 12.
That's probably a good rule.
So I just was curious if that.
Yeah, no, I don't do children either, but for a different reason.
Okay, well, there you go.
Yeah, I don't do children because I don't want to have to prick them with a needle. I mean, it's a considerable amount of blood you're taking too. 10 cc's, because you got 5 cc's in each test tube. 10 cc's for an adult, no big deal. 10 cc's for a child, big deal.
Okay, so another question. When you're doing food allergy testing and you're looking for IgG response, which is what you're looking for here, IgG, correct?
Correct.
Okay. If the patient has had steroids up to 6 months before having the food allergy testing, they get a false safe that comes back because the immune system has been given permission to calm down. Are there any prerequisites that we need to be mindful of and tell the patient, we're going to do blood work on you and do testing. It's the best we can do right now because you have dental needs that need to be addressed and we can't wait for 6 months.
Right. We like to wait 30 days if they've been on immune suppressants, and if they've been on antibiotics, we like to wait 30 days. You don't always have that privilege, but you have to remember also that our test, after we get all the numbers, we divide those numbers into thirds for highly reactive, moderately reactive, and least reactive. So the numbers, while they may not be as high as they should be because the patient's been on antibiotics or immune suppressants, the order of the numbers is still correct. Did you follow that?
Yes.
Yeah, in other words, the numbers may be a lot higher when they were not on antibiotics, but we still divide it into thirds, and then that's where we put the dental material according to the numbers. So it's not the raw number, it's where that number fits into the large spectrum of all of their numbers.
Okay. And now, Teresa had a question, which was, is there any chance that you would add some things to the list, i.e. anesthetics?
No, because anesthetics are toxic to everybody. They numb the nerve. There's no such thing as a biocompatible anesthetic.
Okay, and what about some of the bone augmentation or sutures or things like that? Any chance you would add some of those?
I don't think so. I mean, sutures are something that are in the mouth temporarily. I just don't think it's a necessity to do. It's not something that's going to stay with the patient for any length of time. And don't forget also the reason, if you compare ours to the Clifford test, we have a lot less materials because we have a policy that we have to have 90% of the ingredients. If they give us 50%, we will not put it on our test. If they give us 10%, we will not put it on our test.
You meaning the manufacturer?
Yeah, we have to have 90% of the ingredients. And so I'm always getting people who say, well, why don't you put this on? Why don't you put that on? I would love to if the company would give us the ingredients.
I gotcha. Okay.
Yeah.
Okay. And what about if the person has never been exposed to the material before? I mean, there's so many different dental materials that, of course, they've never been exposed to. They couldn't possibly have an IgG reaction. How do you cover that?
That's right. That's a very good question. That's an excellent question because somebody who's never been exposed to the material before, it's more likely than not going to test okay. They're going to test least reactive. But if you do a whole mouth full of one composite, and that patient gets tested again 2 years later, they just might develop a reaction to it. So that's a very good question. We've actually had patients who are okay with fluoride. And so, you know, there are lots of flowable composites that are loaded with fluoride. They're okay with it. Why is that? It's because they were never exposed to fluoride. They lived in an area where they either had their own well water or they lived in an area that was not fluoridated, and somehow or other, they didn't come in contact with fluoride, so they were okay with it. So the amount of reaction is, you know, how much exposure you have to something determines how much your white blood cells are going to put up with it. You keep eating tomatoes every day, and in no time, you'll develop an allergy to tomatoes. You keep eating eggs every day, and you'll develop an allergy to eggs. But if you've never had something, your immune system at first glance might say, yeah, not too bad. I think it's okay. Interesting.
Anybody else that has any questions?
I have just one more question. I'm so sorry, Dawn. At IFM, when I did my immune module, and we talked a lot about food sensitivity testing, they had recommended that the foods remain in the body. If you're allergic to it, the IgG test, you need at least about 20 days prior to complete elimination. And I know that you mentioned 12 hours NPO. How does food interfere with this IgG testing for materials if it's still in the body? Because it takes about 20 days.
Yeah, sure. I understand. But if it's still in the body, their numbers are going to be higher across the board. Like I said before, their numbers are going to be higher across the board, but we'll be able to see the different proportions. If the numbers are too high, well, then they're off the charts and we can't measure it at all. Did you follow that?
I did follow it, and
that's why we want them to stay away for at least 12 hours. Lower the IgG numbers at least a little bit.
Right. I was wondering if
IgM numbers too fall into that.
Right. I was wondering if wondering if waiting a little longer would allow more sensitivity to this test.
Sure. And if they know they have an allergy, staying away from that food in particular for weeks would be better.
Yes.
Right?
Yes.
Yeah,
absolutely.
Then our numbers would be nice and low and they would be easy to read. But that's, you know, that's not always ideal.
I get it. Thank you.
Right?
Thank
you.
I
I agree
appreciate
with you. We want to try to just get the numbers so that we can fit them in this stupid chart. Really, I'm being totally honest with you. We want to get this readable. Yeah.
I get it.
Yeah, there's not going to be an ideal. The way I learned with food allergy was I gave them a list of 96 foods, and I said, you have about 30 days to eat a teaspoon of every one of these foods so that we can see if you're reactive the first time. But the second time, if we do the test, and you showed up the first time sensitive to wheat, and you show up sensitive the second time, that means you didn't pull wheat out of your diet.
Right.
It's still in there.
Right.
So, but ideally, you can't have the patient go 30 days without eating in order to do the testing for you.
Right. Yeah, can't do that.
No.
I mean, you could do that, but I wouldn't get too many buyers, really.
You know, honestly, a lot of the people who really would even go for testing, at least in my practice, I note that there are a type of patients. I'm a very mixed bag, conventional, and people who seek me for what I do. And I'm not even a biological dentist. I'm sampling, I'm learning from you guys. So when they come in, they're already believers. So I'm preaching to the crowd, and they pretty much know what they're sensitive to. So the possibility exists, but it's hard. Yeah. Thank you. Thank you.
Very good. Very good. Excellent. That's wonderful that you're on board with this. It really is.
And we're trying to broaden some minds and, you know, just stretch your knowledge base. And some of you will come on board and want to learn more, and others of you, it'll just make your practice that much better. So,
right.
But we're not a bunch of crazies.
Not at all. Not at all.
Even before COVID-19, we were telling everybody to take lots of vitamin C, make sure they get their minerals that included zinc. We were saying that for a long time, right?
Yeah, we're smart.
We're smart.
Okay, I'm
science-based.
going to, if there's no other questions, I'm going to go ahead and end the meeting so that I can get this up. It should be up on the website by tomorrow morning. So
Wonderful.
if you want to spread the word out to friends that maybe missed this meeting.
Great.
I'm not sure what we're going to do for Monday. I do know that we have a speaker for Monday, but I'm be looking for your Zoom link so
Okay.
that we can make this a little easier. So I plan on trying to tweak this. So you guys be in touch with either Teresa or with our Facebook page with Lisa on the IABDM. We'll try to get the word out. If not, and you miss a meeting, know that each one of these are being recorded and they're going up on YouTube. So you can have access to this information later. Okay?
Wonderful. Thank you very much for your patience while I tried to figure out how to
Yeah,
get
and
on
Blanche, you and I will practice for next week because you're going to be
Yeah,
on next
definitely.
Friday. We'll have this
Okay.
fine-tuned. Okay?
All right. Everybody
Thanks,
have a great
Blanche.
Easter
Thanks,
weekend.
Yes. Have a very blessed and
Enjoy.
safe holiday.
All right, bye.
Bye-bye.